right, so we're here with Jeff, and Jeff is a first-time patient at Finish Line Wellness, and so we're going to go through a typical day one with Jeff and do a history first to start off. So Jeff has come in and he's given me some info here, his intake form, so I have some stuff to go off of and questions to ask him. So we'll start out first. I know on your intake form you talked about that you have some hip issues going on. Tell us a little bit about when did that start for you?
It started probably when I was in college, late college. I was a lot heavier than I am right now. I was weighing about 275, 280, and now I'm about 215, 220. And so just all that weight was coming down and affecting, well, everything lower body, especially the hips. So I started to develop like this nerve pain that would eventually make my toes numb, and from there it also like radiated into like some lower back pain and just messed up total body alignment. So that's pretty much what the hips. It's gotten a lot better since I've dropped the weight, but I'd have to say that it's still like every now and again slips out of alignment.
Okay. And it's always funny when you ask somebody, like they'll say their hip hurts, and I say point to your hip, and one person will say that my hip, and the other person will say my hip. So it looks like you're pointing to the lateral portion of the hip.
Yeah, like right. It was like right about.
Okay.
Right behind there.
Left side.
Mm-hmm.
Okay. Is it sharp in nature? Is it dull, achy? What's
it can get a little dull and achy. Back when it was really bothering me, it was more sharp.
Okay.
Like there'd be a point where I couldn't like fully stand up straight, and I had to basically make some strange leg maneuver to try and fit the pain around.
Okay.
Yeah.
Okay. So it's progressed since the weight's been down. You think that was a pretty key thing for you?
Absolutely.
Anything else that have you seen other people for it? What else have you done to help it out? Have you done rehab?
I've done some physical therapy before at one of the local institutes for, I guess, like athletic medicine. It was helpful in just kind of creating some new patterns of like physical activity and behavior to make sure that I wasn't going to slip into that sort of lazy, non-active lifestyle that I had back in college.
Yeah, typically you'll see that where if you have pain in an area, you'll have where you're not going to want to use it or have the tendency to use it, and then it will atrophy. So just like you said, and then it'll become hypermobile and the problem gets worse. So.
Right.
How about for right now, though? Does it affect your daily living? Does it affect what you do, what you like to do? Or
every now and again, after like a pretty intense workout, it can be a little dull afterwards. That's where like the dull achiness comes, and it affects some mechanics on certain lifts like squat or deadlift. Like there's just not as much, I guess, confidence that I'm going to be able to do the lift the way it's supposed to be done, because I just have a little bit of a tendency to favor that side, the left hip.
What kind of workout? Well, first of all, would you consider yourself an active type of person?
I would say active, yeah. Not too highly active, but 2-3 times a week, maybe do a workout.
Okay, and what do you like to do when you work out?
Pretty much just weights. I do bike to work pretty often, maybe 2 or 3 times a week. So that's about a 12-mile bike ride. But when I'm in the gym, it's pretty much just like the heavy lifts, because I want to get in and get out as soon as possible.
Understandable. So I know you said back when you were a little heavier, you had some where it seemed like it referred down. Does it refer anywhere now, or does it stay local to the left hip?
Pretty much stays local. It used to refer all the way down to my toes, like when I would be able to actually stand up straight after getting around the pain.
Yep.
I would walk, and it was clear that there was some major problems because my toes would all just become numb.
Okay.
Yeah.
All right. So now more so, with workouts, it's worse, seems like, right?
Mm-hmm.
Is it constant, or does it come and go with just regular activities of daily living too?
Kind of comes and goes. It depends on how much bike volume I'm putting in a week, because just sitting on that bicycle seat's a little uncomfortable after ride after ride after ride.
Okay.
And sometimes when I get back, I don't do any mobility exercises or stretching because I'm just exhausted from the bike ride. Okay. So that's something I should be doing, but when I don't, that's when I kind of notice the dull achiness.
How about now? You mentioned your low back and kind of how that was associated. How's the low back now for you?
It's pretty good. It's very infrequent that I feel any problems at all, really.
Okay.
Again, if there's a stretch of inactivity, maybe I'll start to feel something, but it's a far cry from where it used to be, where you get that low back sharp pain where you feel like you have to just go face down into the carpet and scream in agony.
Yeah.
Yeah.
All right, let's move to the shoulders. So you mentioned that you had some shoulder issues. Is that right shoulder? Is it the right side?
It's actually a little bit
diagram.
of both. Like the right shoulder will kind of like click after a little while, just trying to like move it into certain positions, which can affect like a bench press motion or any sort of overhead pressing motion, because sometimes I'll get to the point and it'll kind of click in, and then it being so far out of alignment, it'll start to come down and have some real big pain on the right side.
Okay.
And I've had some rotator cuff problems because I'm a left-handed thrower in sports, so I've had some rotator cuff tears and such like that.
And that was tears that were confirmed by imaging, MRIs at one point or anything?
No.
Okay. Just
probably
diagnosed that way through
WebMD or something like that.
Yeah, I've heard that one before. All right. So you said when you used to throw a lot, that's when some of the shoulder stuff started. Is that for your right side as well? I mean,
No, it was never for the right side.
So when you're throwing, your left side hurt more. Right side. When did that come about? When does it start?
I was a swimmer in high school, and so a lot of the overhead, like stroke motions, would just after doing that day in and day out for hours and hours on end, would eventually come to the point where it just kind of started clicking out of place.
Okay.
Not like fully out of place, like dislocated, but just enough where, again, like doing pressing motions, I could feel it.
Didn't feel right. Yeah. So now, how's it progressed? Worse, same, better?
It's about the same as far as like the clicking thing. It's preventative and really trying to go for a lot of strength gains in pressing motions, just because I know that it's a possibility that it'll slip out.
Okay. So it prevents you sometimes from doing a certain thing based on that?
Yeah.
Okay.
That's right.
How about quality of the pain? So is it sharp? Does it ever like actually shoot anywhere? Does it go down into your arm?
If it were to be on a pressing motion, yeah, it's pretty sharp. It's probably like a 7 to 8 on like a intensity level.
And does it shoot down the arm? Do you ever feel like where it zings?
No, not all the way down the arm. Just kind of like centrally located right around,
Okay.
I guess, the rear delt.
Okay. How about if you're not doing activity? You know, if you're not moving the shoulder, does it bug you then? If sometimes you just
No, not really.
Okay. All right. How about just family history for you? Do you have history of people that have had full back issues, hip issues, shoulder problems?
No, not really. Not a lot of people that I can recall.
How about for you? History of trauma, illness, surgery, major history of...
Well, I do have a bleeding disease, hemophilia, von Willebrand's disease, so it's like a clotting factor disease, so it doesn't allow the like bumps and bruises and twists of joints to heal as quickly. And so just wear and tear over the last like many years has just accumulated and contributed to a lot of those
Tougher to
joint
recover.
pains.
Yeah. So all the more reason to get you lined up then, huh?
Mm-hmm.
All right, well, let's do an exam. Okay, so first I want to just see you move around, so we can see how mobile you are or aren't. So first we'll just have you touch your toes, so just go ahead and do now as far as you can go. Good, any pain with that at all?
No.
Okay, so good flexion, let's see, go extension. Yep, lateral bend. Good, and lateral the other way. Let me just see you rotate back and forth like that. Pain in the hip during those at all?
Just a little tightness, I guess, on the left side. Yeah.
Okay. Same kind of idea for your neck. So I want to see you go chin down to your chest, go all the way up to the ceiling. Good rotation. So I want to see you go over your shoulder, back the other way. Looking straight ahead at me, just tip your ear to your shoulder, and then tip your ear to your shoulder this way. Good. Okay. I want to see the range of motion in your shoulders. So let's go to flexion here. Let's go up. Yeah, let's go extension back. Good. Let me see. I want you to turn around. I want to see this old guy this way and then the other way. Yep. Good. And then the other side. Yep. Good. Okay. Good. Okay. Let's get you up on the table here. All right. So go face up first for me. Check your mobility here. Pain in the low back at all? Hip?
No.
Oh, good. Any pain with this in the hip? Low back or otherwise? No? Go up here. Let me know, is this any pain at all?
No, just slight like tightness, discomfort.
And that's coming right in here?
Mm-hmm.
Okay. Let's bend this guy. Put that there, let that fall. Pain in the hip with that?
No.
No, okay. I'm gonna go one more on you here, this one here. Pain with that one?
No, just a little tight.
It's okay, some more tightening. I want both knees locked out here. I want you to lift both legs at the same time off the table, just about 6 inches. Any pain, low back, hip, otherwise?
No.
No? Okay, let's keep you there. You can relax for a second. Move your head around a little here. Any pain here?
No.
Any pain with that?
None.
Push your head up here. Any pain here?
No.
I'm gonna pull you. Any pain there?
No.
Nothing. Good. A little bit of an alignment deal there. You feel that?
Mm-hmm. I do.
Left side. Okay, let's flip you all the way over on your stomach. I'm just going up the spine here, feeling for some asymmetry, finding areas if there's pain or tenderness. So how about in the upper back here? Do you get any pain in this upper portion?
No, not really. It can get a little tight, like during bike rides or anything like that. That's like because I'm probably looking straight ahead.
Yeah, you're flexed over the front.
Mm-hmm.
Alright, I'm gonna move you around a little bit. Let me know, is there any pain there in the hip or back?
No.
No? How about this way?
No, none.
No? Okay. Left side here, any pain there?
No.
No. How about that one?
I can feel just like a slight discomfort in that sort of left hip area.
Okay, and it's on the lateral, it's out here.
Right.
You're not feeling it so much in here.
No.
Okay. Okay, let's have you come on up. I want you seated right on the table here. Good. Alright, scoot back to your knees there. And with this one, first I want you to go up and in with your ankle. So I want you to go up and in and just keep it up and in like that.
Mm-hmm.
Just gonna test the strength a little bit. This one up and in, and a little bit more up if you can here. Yeah, good. Okay. This one I want you to go down with your foot and out and just push against my hand here. Good. Let's go this one down and out. Push against my hand here. Okay, good. Alright, with your arms, I want you to kind of make, just like tough guy here, I'm just going to pull. I want you just to resist me here.
Okay.
Yeah, good. Good. Okay, let's flip those. Like that. Yep, push against my hand. Good. Push, push, push. Alright, let's go up like this with both arms. I want you to bring them up here. I'm going to push down right here. I just want you to keep it up there nice and high.
Okay.
Okay. Strength is okay. It's a little tougher there, isn't it?
It is. Yeah, I can
You
feel
feel
a
that?
few of the tendons kind of moving around.
Yeah. Is it painful too, or does it just feel like weaker?
Just feels weaker.
Okay.
Yeah.
Let's kind of have you splay your fingers out like that. I'm going to push them in. Just keep them nice and wide apart like that for me. Yep, good. So this is just testing the nerve root strength. And so why we do this is, say there's weakness like for you had on this one, a little bit of weakness on the left side.
Mm-hmm.
The deltoid muscle is innervated by the C5 nerve root. So if there's weakness on that left side, where do you suppose I'm following back that nerve root to? When we're looking at x-ray, I'm looking at what level? C5, right?
Yeah.
So we just want to make sure if there's any compression there that we correlate that to the spine and where that nerve exits out. So, okay, well let's go take some pictures and we'll go from there.
Okay.
And we'll go a little bit lower than usual. I don't want your arms just out to the side like that. Okay, your arms can just hang for this one.
Mm-hmm.
Thoracic region. imagine view. For this one, I want to see right here. I don't want to see it through the mouth, so we're going to get the teeth out of the way. So open up as wide as you can go. Arms extended forward and go up, touching if you can, but yeah, up that way. Just come back just a little bit. Nice. All right, so we're back here in the exam room with Jeff, and we are looking through his x-rays, and pretty much by the time you do it and you go through the intake with somebody, you do a full history workup, you get some examination things done, some special tests that we did, you kind of have a pretty good idea of what you're going to see on x-ray, or at least you hope that's pretty much what it is. Usually if it's not what you think, it's usually something worse. But so we're going to go through his x-rays, and we want to do that so that Jeff is educated in why we're treating him and how come we're treating him that way, and really not so much like is there an issue, because he came in telling me that there's an issue. It's more to what extent, and how do you fix it, and what's it going to take to fix it, right? So this is a lateral view of Jeff's neck, and you're looking this way in this view, as you can see. You see how it's really straight?
Yeah.
So you want to have curvature, so you want to have your cervical spine curved around like this way.
Like sort of going up like...
Yeah,
okay.
So, yeah, like this. And so what you see obviously is that you don't have that curve, and actually starting to produce what's called a reverse curve in the neck. So it's not normal, but it's something that unfortunately with our sedentary and texting and gaming society, we're seeing more and more forward head posture. So the necks are not as normal curve. We're seeing that, and unfortunately it's in younger kids that we're seeing that too. A lot of them coming in with, we call it tech neck, but which might make sense for your background too. So and then you want the angle of C1 to be about 43 degrees, and you can see that that's not that. So you want that thing tipped, but you can see if it was that, how this curve would follow suit, right? And then another finding too is you can see the lateral flexion of C1. So if you picture the X-ray beam coming in to the side to your first cervical vertebra here, you see how that it looks like there's a little ring on there. And so you can see that it's laterally flexed a little bit from the lateral view too. So other things, you want to look at degenerative changes. So when you look at the disc spacing, you want to have nice clean end plates, no spurs coming off of the segments, and we do see a little bit of whitening down here, but it makes sense because when you're lacking that curvature, you're lacking springiness to your neck. And so what'll happen is over time, that just the pressure of your head is going to keep pounding down on that neck. And what we see a lot of times is when people have a straight neck, we also see some curvature in their thoracic spine as well. Oftentimes correlating to a scoliosis or some kind of curve like that, left to right curves. So this is more an issue front to back. So,
Gotcha.
So here's we'll go to the thoracic view first, moving on down here. So this is your thoracic view. You can see it's pretty evident. You don't have to be a radiology specialist to see that there's a curvature in there. But the big thing for this is that when you have some kind of dysfunction like that, it's going to correlate to your upper back muscles, tendons, ligaments, and so that correlates to your shoulder as well.
Of course.
So you can biomechanically, you can strengthen, stretch the rotator cuffs and make the shoulder function pretty good for a while, but if the structure where it's attached to is off, then you're going to have issues come back up eventually too. So we want to always know, where's the source of the problem. So we go back to the immediate source and then work our way kind of out to the shoulder and down from there. So this is your pelvis view. So you can see on the left side, this would be your left is hiked up. It's what we call a flexion of the left ilium, so flexion of the left hip, you can say. So you're stuck up like that, and what that'll do is it'll cause the ball and socket of your hip to just articulate a little bit goofy on that left side. And so it's really more than anything, you're getting kind of a tracking issue, and that's going to affect the IT band that crosses the left hip there and down. So At one point, you're saying that you had referral pain that went actually like down to the toes even.
That's right, yeah.
And that's more talking specific to this dysfunction and the nerve root compression at the spine and correlating nerves there that travel down the leg. But the irritation, mostly from what your exam findings show, is that really it's more specific to the hip. It's a biomechanical issue at the hip itself. So here's a frog leg view. So we're just trying to see any degenerative changes here on the acetabulum, so the rim where your femur comes in here, so the ball and socket joint. And what we see a lot of times is when people have hips that are not aligned, like we saw in that last view, is that we'll get kind of spurring going on. So you get this uneven wear and tear on the rim of the joint here, and it'll start to become more white and arthritic and degenerate, and then you'll get some spurring. It looks like some of that's starting, but kind of early phases for that. So, and it should be because you're 32, so it shouldn't be. Hopefully, you don't see too much degenerative changes on that. So then the question becomes, then what do you do, right? So through correction, there's a few phases. The first phase in corrective care, we say, is you correct it. So it's like, how do you make this curvature not look like that anymore? And that's going to take time. And it's really based on what I call the big three. It's based on symptoms. What symptoms did the person come in with? How structurally, how far off is it? Just straight up A to B. If we're saying that your structure is going to dictate your function, then I want to know, correlating to the hip, I want to know how far off are my hips, and how does that relate to the specific to the hip joint. And then the last one is degenerative changes. So how much has it wore out really? So how much degenerative changes have you had? Do you have calcifications? Do you have arthritis? And that's going to be a limiting factor in the ability to correct. And also, the more that progresses, you're going to have a diminished return. So it's going to take more care, and it's going to take longer to probably not ever get as much back as well. So those are kind of the big three as far as care goes. So, any questions on your X-rays or thoughts that came up?
No. It's just interesting findings, especially with like the little slant for the right to left hip area, and then a little bit of the curvature of spine. So it's like much easier to see how it's all kind of relating to one another, and what kind of steps need to be done to make all that better.
Right. Yeah, and when we do follow-up X-rays, you want to see positive changes. Well, right. First you want to see, did it not get worse? Because what you've done for 32 years has led to this set of X-rays, right? So you want to see that, symptomatically you're better off, hopefully symptom-free, and that the problem didn't get worse than it already was, and then, did it get better from there? And
right.
So that's what you hope to see as well. So, and for you, who's got some degenerative changes, but not really that progressed yet, for sure, it's very very optimistic as far as your prognosis goes. It's definitely correctable.
Great. Good to hear.
Okay, so let's have you go face up first. Good. One more time here. Look good. Feel it's still a little bit of a knot there on the left, so that'll come in time. Just takes more reps. So let's get you flipped over. Okay, big breath in and out. Good one. Okay, big breath in. Nice. All right, so we'll take and align the pelvis now. So we're going to adjust it so as to induce extension of this left side of the hip here. So we're going to move this so when I adjust it, it's going to kind of switch the posture to more of an extended, and then we're going to take and adjust this one into more flexion. So I want you to lay on your side and just face me this way. flip you, other side. Okay, big breath in. And out. Good one. Cool. Feel okay?
Yeah, very good. I could feel a lot of the spine kind of moving when you did those ones too, and
Mostly in here.
yeah, mostly in there. But then also when I flipped over to my side, I could feel like the shoulder just doop, a
Yeah,
little bit.
yeah.
That
So
little shoulder.
that'll take some more work. We definitely got to get on stability of the shoulders and working the rotator cuff. And for you, it's the movers of the joint have pretty decent strength, but what we want to work is the little tiny muscles that stabilize the joint
Yeah.
in the rotator cuff. And so one thing with a forward posture like that is that you have this more flexed posture, so it gives you this rolled shoulder.
Yeah.
And so we want to work to get that neck back, that curvature of the neck, so that the shoulders can sit down too, and we'll get the biomechanics of the shoulder right, and then strengthening just is all that much more beneficial. All right, so we're working the stability, the stabilizers of the rotator cuff, and so what I want you to do is step on this band, and we're going to do it on both sides, so either side. I want your feet nice and square, that's good. And what I want you to do is I want you to start actually internally rotated at the shoulder, so it's kind of like you're watching your watch here, and then you're going to move out to the side, and as you move up, I want you to gradually go to external rotation, just like that. Yep.
Okay.
You don't really have to go above the ear, you're fine there, and then slowly come back down and rotate back into an internal rotation. So working up, palm to the sky, and then back again. So this band is a really light band. It's the lightest band we have. And the reason again is because we want to facilitate the rotator cuff muscles, which are tiny muscles. And it's not like the deltoids and stuff that you see here. It's the stabilizers of the joint.
I can feel that it's like a little click into place, every single one. No pain or anything, but just can feel that that's where it's working.
And let's flip sides, and let me see you do it on the other side too.
Okay.
Palm up, look straight forward. It's pretty good. Any pain with that at all?
No.
No. So he's working into external rotation. Again, we said that with the straighter neck, and the more flexed posture, it's really biomechanically a tough position for the shoulder. So we see a lot of most shoulder injuries are when you're internally rotated like that, especially weight bearing. And so he's good posture. He's up like this, and we're working really the back side of the cuff. So